ready to answer all the questions if you have some.
Thank you, Dr. Dersot, for a very informative and impressive presentation. So we got only 3 questions here,
Okay.
and I'm here to translate it to you so you can answer one by one. Okay, so the first question is about the lateral slide flap. Please speak more specifically about evaluating the surrounding soft tissue for the indication of the lateral slide flap.
When I was a student during my postgraduate of periodontology, the professor says always, if you want to use the lateral sliding flap, you need to have 3 times the width of the gum recession. That means if you want to cover a surface of, let's say, 3 millimeters width, you need to have 6 millimeters on the mesial aspect or on the distal aspect of keratinized tissue. So this is the first part of my answer. The second one is the direction of the vertical incision. If you stay strictly vertically, you will not be able to move the flap or in the mesial or in the distal direction. If you want to move the flap, you need to orient it in the direction of the movement you want to give to the flap, your vertical incision. That means that if you want to move a flap in a mesial direction, you go vertically to the mucogingival junction. And when you are at the level of the mucogingival junction, you go strictly in the mesial direction to continue your vertical incision. And at the end of the elevation of the flap, usually the first part of the flap can be in partial thickness, and the rest of the flap can be in full thickness. And when you have elevated your flap due to the oriented vertical incision, the flaps go spontaneously on the root surface, and you don't have to tract the flap. If you do 2 strictly vertical incision and you want to move the flap on a lateral direction, you tract on it. And even if you do very slight sutures due to swelling, usually the flaps goes out and goes back to its initial direction. I hope that my answer will give some lights on these specific techniques.
Thank you. So the second question is, do we have to prepare the root surface before root recovery procedures? If yes, how should it be?
I scale. I only scale. I don't do any chemical preparation, only scaling with curates, for example.
Thank you. For the third question, please explain the mechanism of the connective tissue graft in instances where there is no bone supporting the graft. That means that we are doing the graft on an exposed root. Will there be a risk of a periodontal pocket development?
If the root surface is clean, if you have eliminated all tartar, if you have eliminated all dental plaque, and you use only curates to prepare the root surface, several papers with histology show that there is hemidesmosome in direct contact with the root surface. And if you probe several months after the surgery, there is no pocketing. only there is a kind of reattachment on the root surface. It's quite the same when you treat a patient with deep pockets and you do only non-surgical therapy. You observe that at the end of the non-surgical therapy, the pockets are less deepened. Why? Because you have reattachment on the root surface due to the presence of hemidesmosome. So it's totally the same when you put soft tissue on the root surface. But the challenge is to put a graft, that means without any blood supply, on a hard tissue surface, of course, without any blood supplies. We don't have any blood supply in the dentin. So when you put the connective tissue and you cover it by a coronal advent flap, the risk of necrosis is quite null, quite zero. And you will not have any pocketing after the end of the healing. So you need to have a very clean surface of the root. So don't hesitate to use curette and to eliminate it. I will say very few surface of dentin, just to have clean dentin.
Thank you. So the next question is, can we do a GBR or bone graft prior to a connective tissue graft?
Unfortunately, no. Unfortunately, no. It's impossible. Today, if you want to do a bone graft, you have to feel something. When you do a bone graft, for example, when you do a bone graft in a vertical periodontal defect around a tooth, you feel a defect, you feel a hole, and the material you use or the bone of the patient you use goes in a hole, in a recipient on the surface. If you use or the bone of the patient or a bone substitute, how you can keep the bone in place? And the problem is not the bone. The problem is the periodontal ligament. You don't have any periodontal ligament, so you are not able to do any regeneration on the exposed root surface. So unfortunately, today, we don't know how to recreate bone on an exposed root surface. Even if some histologic study have been done with Emdogain, and some practitioners use Emdogain before putting the connective tissue graft on the root surface. But even with Emdogain, if you have regeneration, it is about some very small area at the deepening part of the recession. Unfortunately, it doesn't go to the cemento-enamel junction. So again, today, we are not able to recreate bone on the buccal surface just over the exposed root surface.
Okay. The next question, how do we evaluate the risk of reoccurring of the recession after treatment?
I will say that the great majority of adults, recession are associated with heavy brushing techniques, or they use hard toothbrush, or they brush horizontally, or they press too hard on the toothbrush. So I think that to avoid any new recession, first, totally change the behavior of our patient, goes to vertical brushing techniques first. And second, inflammation. If you have a patient who don't have any good plaque control, and there is a soft tissue inflammation, maybe another recession can occur in the future. So the two conditions are avoiding any heavy brushing techniques, avoiding any plaque-associated inflammation.
Thank you. The next question is about post-operative medications. Is there any thing to pay attention to?
No, I will say that the main risk usually is on the palate because of the presence of an artery. So if you take, if you use the technique I have shown in my small video, you have a risk to cut the artery. If you use the technique, the other technique, which has been developed by several practitioners, that means to take a free gingival graft and then to eliminate the epithelium, this free gingival graft is very superficial. So the hemorrhagic risk is very low. I have never seen a complication like infection. Sometimes there is a heavy swelling. So before the patient leave my clinic, we gave him a ice pack. And I ask my patient to have ice pack for several hours, if it's possible, all the day long, because the best way to avoid or to lowering swelling is to put ice on the cheek. But the main complication is bleeding risk on the palate.
Okay, so I think that my speaking was not very clearly. So you were mentioning about the complications, right?
Yeah.
Yeah, but the question was about the post-operative medication.
Ah, medication. Okay.
Yes, the medicine.
Medicine. If you see, for example, recommendation for a scientific society, they say that for this kind of surgery, you have only to give a painkiller and mouth rinse. But as I told during my lecture, my patient, as your patient, when they get out of my clinic, they want to go or in their office back, or they want to go at home with their family. And they don't want to be disturbed by heavy swelling for 4 or 5 days and sometimes bruising. So I systematically gave corticoids. And as I gave corticoids, I gave antibiotics, because corticoids act directly on the defense system of the organism. And I don't want my patient to have any infection, because I gave to my patient corticoids. I gave only corticoids for 4 or 5 days maximum, and mouth rinse with chlorhexidine. But I also ask my patient to not tear on the lip to see how is the healing. I don't want my patient to put his tongue on the lower lip just to play because it is funny, and I don't have any pain in just after the surgery because the anesthesia is still present. I don't want my patient to bump its limp when he do mouth rinse. I don't want anything to disturb the healing. So I always say to my patient, do you want to see the result at the end of the surgery? If yes, I gave you a mirror, you see only for a few seconds. But after, when you go back to home or when you go back to your job, don't give the opportunity to your friend or to your family to have a look, because you need to tear on the lips, and I don't want you to disturb at any moment the healing. So medication, and don't touch, wait, don't touch.
Okay, thank you. The next question is about the suturing technique in case of a coronally advanced flap.
I use small pieces of composite just at each contact point before doing the surgery. Then I do my surgery. And to help me to move the flap in a more coronal direction, I go around the small pieces of composite I have just sticked at the level of the contact point. So it's not like flossing. I don't want to go across the contact point. I want that my sutures be over the contact point, and through my sutures, I want to move my buccal flap in a more coronal direction. So this is the technique, one of the techniques to move in a more coronal direction the flap. Some other practitioners propose to put just in the middle of the buccal aspect of the crown small pieces of composite over the sutures when the knots have been done, and to tract the flap in a more coronal direction. But definitely I prefer to go all around the contact point in which I have put some composite before the surgery. This technique, these sutures have been described by two German periodontists, Zur and Hürzeler, and they have written a wonderful book, a pink book from Quintessence edition, and they perfectly describe this kind of sutures. It goes around the contact point, but not to go through the contact point, they put before a very small amount of composite. And when you take the stitches, the sutures out 2 weeks after, it's very easy to take those small pieces of composite out, because I don't use any how do you say, fluorhydric acid, not fluorhydric. When you do a composite, you put something on the enamel. I don't remember the English word, because I don't do any restorative dentistry.
Etching?
But, etching, yes. I don't use etching. No etching. Only the liquid part of the composite and the past, the heavy composite just over it. That means that when I take the stitches out, it's very easy to take with any, let's say, a scaler, to take out the piece of composite I have just stick over the contact point.
Okay. The next question is, when can we start orthodontic treatment after soft tissue grafting?
I will say 2 to 3 months.
Thank you. The next one, what is the treatment modality for molars with furcation involvement?
It's very more difficult, definitely.
Yes.
If you have furcation involvement, maybe you can try to use Emdogain, and to because one of the I will say one of the first indications for Emdogain is a regeneration of vertical defect around the teeth, but it is also class 1 or class 2 furcation involvement. I say class 1 or class 2, not for from the Preston-Miller classification, but class 1 or class 2 from the classification concerning the loss of attachment in the furcation from a horizontal consideration, horizontal direction. So maybe it's better to use Emdogain to try to regenerate a part of the periodontium in the furcation. If there is no bone loss in the furcation, again, you can do a plain connective tissue graft covered by a coronal advance flap, and you will cover also those areas. The main problem is when you have bone loss in the furcation in an horizontal direction.
Okay, thank you. For the next question, can you give the specific location for harvesting the connective tissue?
I will say that there is two ways to take a connective tissue graft. The first one is the small video. In the small video you have seen, and the second one is to take the amount of connective tissue you need through like a free gingival graft. So you take the sample from the palate as a free gingival graft, and secondly, you eliminate the epithelium with a blade. So you will have at the end only the lamina propria, and this lamina propria is the very interesting part of connective tissue because it is very dense. So you can use it, for example, through tunneling techniques, but also with a coronal advent flap. So all the technique I have shown you in the video are the same techniques you can use for a free gingival graft, but before using the graft, you eliminate the epithelium with a blade.
Okay.
I have also something to add. The protection of the palate. What we can do to protect the sampling area in the palate. You can use a collagen device and putting a suture going across the collagen just to stick the collagen in the area you have taken the sample. You can ask your pros to do something like an aligner, but to cover the integrity of the palate and to protect the sample area. There is several options to protect it. In my practice, I put a piece of collagen. I do sutures crossing over the collagen. And at the end, I use periacryl. It's a kind of glue. And I just put some drops of periacryl on the connective, on the collagen sponge, and it creates something hard on the surface, and it's like, and it acts like a protection of this area, because all the patient, their main complaint is not the receiving area. Their complaint, if they have their complaint, are about the donor side, not the receiving side. So developed heavy techniques to cover, to protect the donor side.
Thank you. For the next question, do you have any specific scaling tool in root surface cleaning? prior to grafting?
Any
Specific, any special?
concerning bleeding?
No, do you have any special tool for scaling, for cleaning the,
For scaling?
yeah, for
For
scaling?
scaling the root surface, you mean?
Yeah, yeah.
Yes, Gracie Curate.
Okay.
Only Gracie Curate.
Okay, the next question is about the case report with recession in the children's 6 to 8 years old child. In your presentation, were soft tissue grafting indicated on these cases?
Yeah.
Were soft tissue grafting indicated? Thank you.
I try when it is possible to avoid any free gingival graft. Usually those kind of recession for the children are in the incisor, in the lower incisor area. And if there is a crowding, you can observe that the tooth in a more buccal position have sometime a recession, but the neighboring teeth in a more lingual recession have very high amount of keratinized tissue. So if I have to cover a root surface, if I have crowding, and if I have a lingual tooth or lingual teeth with a high amount of keratinized tissue, I will do a lateral sliding flap. I think that sometimes it's very difficult to do surgery with children. So I try to have only one surgical site. If you need to do a free gingival graft, you take it in the palate. That means that you will have 2 surgical sites, and it's more difficult to deal with young children. So definitely, I try to do lateral sliding flap if the local condition allow me to do this.
Okay, thank you. For the next question, it's about the indication of the tunneling technique.
Tunneling techniques. I will say that if you have a recession deeper than 4 millimeter, I think that the best surgical technique is to do coronal advent flap. If you have a recession less than 4 millimeters, the best techniques is tunneling. In the two choices, you use connective tissue graft in the 2 choices. But the main interest of tunneling is to create a band of keratinized tissue and to move coronally the flap without any incision in the interdental area. When you do an incision, you cut the blood supply, and sometimes you can have some problem in the healing in this interdental area. So it's more easy to avoid those complications by doing tunneling techniques. But tunneling techniques is more technical because you need to go under all the soft tissue without any incision. So you need to use very small blades, and the Viper blades, for example, is a very good tool to go under the soft tissue. You have to go under each papilla without cutting the papilla at their apex. So it's very technical, it's very sensitive. On the opposite, if you do a coronal advance flap, in my mind and in my hand, it's more easy because you only have to cut the gum, of course, with a specific direction, partial thickness, full thickness, partial thickness. But in my hand, it goes faster to do a coronal advent flap on a connective tissue graft than to go tunnel techniques. But I will say that the limit of the tunnel techniques are gum recession higher than 4 millimeter.
Okay, thank you, doctor. The next question is, please describe the suturing technique for fixation of the connective tissue into the recipient.
Oh, okay. Uh, um, to fix the connective tissue, you need to be able to do suture on the periosteum. So your incision need to, you have to do a partial thickness flap and to leave on the bone the periosteum. And the sutures are done in the periosteum. And of course, there is some connective tissue on the periosteum. But if you want to stabilize your connective tissue graft, you have two sutures on the periosteum. And you have to use 7.0 sutures, resorbable, of course, but 7.0 and a very short needle, just to be able to get in and to get out very easily and very quickly. So 7.0 absorbable sutures, and to prepare your recipient site and to leave periosteum and some connective tissue fibers on the bone.
Thank you, doctor. The next question is it okay to leave part of the grafted connective tissue exposed, or it have to be completely covered by the flap?
No, you can leave a certain amount uncovered, but the great majority of your graft need to be covered if you want that these small piece of connective tissue not covered will survive. Of course, there is no direct blood supply, but the blood supply is coming from the periosteum, and there's some connective tissue fibers you have leave it on it, and it comes also from the inner part of the flap, which cover the connective tissue graft. So to summarize, if the great majority of your graft is covered, the risk of necrosis of the small part non-covered, exposed, is very low, quite null, quite zero.
Thank you. The next question is, what is the suitable thickness of the connective tissue graft, you think?
I will say that it is about between 1 millimeters or I will say 0.6 to 1 millimeter. If it is too thick, sometimes the aesthetic result is not good. You have like a bump, something with a kind of convexity. If you cover, for example, a recession on the buccal aspect of the root of an upper canine, and you have at the end of the healing a kind of bump, in a way it's not too bad because you have recreated the volume which exists on the buccal aspect of the root naturally. But if it is in an anterior, for example, lower incisor, and you say to your patient that the result will be wonderful, and he will say no difference between the connective tissue graft and the existing soft tissue, your graft need to be a little thin. So 0.6 to maximum 1 millimeter.
Thank you, doctor. I just went back online. Did I miss anything? Okay, so the next question is, in your opinion, are there any differences in the treatment result when we choose between different grafting materials, between the autograft, the alloderm, or recently the PRF?
I have no experience with alloderm because alloderm is forbidden in France because it's human material, and human material is forbidden. So the company who sell alloderm, it is Bio Horizons. It's not available in France, so I don't have any experience. And again, I don't have any experience with PRF in those indication. I think that it is so easy to take some connective tissue grafts from the palate of our patient, and you can take a small amount, and you can also take huge amount of connective tissue if you want to cover, let's say, the quite all one arch in the same session. You can take a sample on the both sides of the palate, and if you protect this area, your patient will have no pain on the palate. So I prefer to use definitely a connective tissue graft. I think that the connective tissue graft is a gold standard, but I can understand that for practitioners who are not used to do those kind of surgery, to take a connective tissue graft on the palatal aspect, they are more tired by using a substitute. So of course, maybe PRF, maybe alloderm, or other devices. In my slide, I gave only the name of a product for Geistlich, but today a lot of company proposed, let's say, a soft tissue substitute, but I don't have any experience about those substitutes, except what I have reading in the papers in literature. For me, it's very easy. I'm practicing in some months. I will be practicing since 41 years. So, and my practice is limited to perio and implant surgery since 31 years. So taking a piece of connective tissue in the palate of my patient take some minutes, 5 minutes, more, not more. And if I need small piece, I take a small piece. If I need a large piece, I take a large piece. And some months after, if I need again connective tissue, I can come again in the same area. Healing is wonderful if you can help the nature to give you good results.
Thank you, doctor. So the next question, should we do grafting on teeth with recession to the apical third? And
to the apical third. It depends.
On teeth with recession to the apical third.
I have shown you a case.
That means a very deep recession.
Yeah, yeah. It depends also of the bone level on the mesial and the distal aspect of the tooth. If you have, you have seen the case I have shown, lower lateral, central or lateral incisors. And 2 weeks after my surgery, the GP need to do root canal because I think that I have cut the blood supplies to the tooth. That means that the recession goes to the apex. And even if it goes to the apex, I have done the root coverage, and the teeth, the tooth is still in the mouth of the patient. And if I probe, there is no pocketing on the buccal aspect of the root. So, of course, you can try to save each teeth, but I think that your decision concerning concerning gum recession depend also of the level of the bone on the mesial and on the distal aspect of the considering tooth. But why not?
Okay. Thank you, doctor. So 20 questions so far. And we are currently do not have any more questions.
Oh, wonderful.
So I think it's time to get to the discussion with Dr. Nam, Dr. Phạm Hoàng. He's gonna have some words.
Yeah.
Dr. Nam, please.
Good evening, Dr. Dersot.
Hi.
So very thank you for your very interesting and comprehensive presentation. And also you have many experience in this topic, and I like your answer on the question part very much. So I have one more question for you.
Yeah, of course.
So in your opinion, so how do you think about the changing the biotype, the phenotype of periodontal tissue before the orthodontic treatment?
Do you think that an orthodontist is able to change the biotype of gingiva through orthodontic treatment?
So in case very thin,
I think that I will say that I will say that from a periodontal point of view, the main objective of orthodontics is to center the tooth in the bone corridor, in the periodontal corridor. If the tooth is perfectly centered, there will be no recession.
Yeah.
Changing the phenotype, we can modify. I prefer to say modify than changing. Phenotype is something in our DNA. And people are blue eyes, people are brown eyes. We have patients with thick periodontium and we have patients with thin periodontium. And you can modify in some area the thickness of the soft tissue by doing graft or free gingival graft or connective tissue graft. But the main objective from a periodontal point of view concerning orthodontics treatment is to keep the root in the bone corridor. I know that concerning extraction and orthodontics, there is a trend today to say that we can do ortho without any extraction. And some companies sells self-ligaturing braces and say that there is no limits or quite no limits. But what they argue in their advertising is not supported by the literature. And the literatures say that, of course, you can move teeth in a more buccal direction, but there is limits. And when the roots get out of the buccal limit of the bone, you create a high risk of recession to happen, even if the gum don't move. But some years after, if the plaque control is not good, or if the brushing technique is too hard, we will have recession. Yeah. So please, and this is for all the orthodontists, try to put the roots in the periodontal corridor, in the bone corridor. Yeah. One of my professors says extracting a tooth is not taking the heart of your patient. Your patient will be still alive even if you extract 2 teeth. Mm-hmm. Yeah. But if some orthodontists continue to align without consideration of the position of the root in the bone corridor, I will have again a lot of root recession to cover during the 2 years I have to practice before I will retire.
Yeah. So thank you. Các bạn có câu hỏi gì nữa không? Thì các bạn hỏi, còn không tôi nghĩ rằng là tôi thấy cái bài trình bày nó cũng khá là rõ ràng rồi đó. Thì bây giờ là
So we are currently not having any more questions.
Okay.
Doctor.
So I want again to thank you, all the groups. I want again to thank all the practitioners who have been on your computer just to share my webinar. I hope I will have the opportunity to visit your country and maybe lecture in one of your dental congress. I know that Vietnam goes in a perfect way through this pandemic in opposite of other countries, and for example, France, where we have a lot of people dying. Again, a great thank you for all of you, and hope to meet you in the next future in your country.
so thank you.
Thank you, Doctor.